Hello, my name is Dr. Monica Gandhi, and today I'm going to talk about HIV and women. So if we discuss this, I really want to go over the epidemiology of HIV in women, HIV prevention in women. We're going to talk about HIV treatment differences in women, ART and pregnancy, and finally end with primary care for people living with HIV who are women. So the latest statistics from UNAIDS shows that adults and children estimated to be living with HIV, that of the 37.7 million people living with HIV, 51.2% are women, or 19.3 million. And that's out of 37 million adults. Now, here in the United States, that is skewed more towards men, our proportion of those infected with HIV. But really, the worldwide pandemic is showing us that we have almost more than 50% in women. In many countries, including the United States, the risks in women really cluster with certain risk factors, which is disempowerment of women, poverty, interpersonal violence, self-esteem, alcohol, drugs. These are really the main factors of poverty that you see here in the United States with the red column, and what happens here on the right, which is really that we're seeing an exploding epidemic of HIV among women in the South and Southeast. So let's talk about HIV prevention in women. Now, there are 4 PrEP options that are available in the world. Unfortunately, they're not all available for women. And that really has to do with some of the trials not being performed in cisgender women, but only being performed in cisgender men. So for example, we have TDF and FTC, many clinical trials in men and women. We have TAF and FTC, but that has only been tested in men, or in men who have sex with men and transgender women. We have the vaginal Tapering ring, which is our option in women. And then we have Intramuscular Cavitagover, which is really the option for both men and women. And we'll talk about each of those options here. So in terms of TDF, FTC, really we had these major clinical trials that I show here are the major clinical trials that show the utility of pre-exposure prophylaxis with TDF, FTC in men and women both. The IPREX trial was the first trial that was only performed in men who had sex with men. But then the Partners PrEP and TDF2 trial were essentially studies that were performed in heterosexual men and women. The Partners PrEP trial was really the first study to show the effectiveness of TDF-FTC in men and women. And because women knew the status of their partners, there was very high adherence in this case, and there was very high efficacy. Women 71%, men 63%. The TDF2 and Bangkok tenofovir study also showed effectiveness. Bangkok was in IV people who use drugs. But the FemPrep and Voice trial showed no efficacy at all of TDF-FTC for women. These were sexually active young women. And really the problem and why these studies were stopped was due to low adherence to the HIV PrEP medication in women. As you can see here, by self-report, adherence was very high, 91% in Voice, 95% in FemPrep, but plasma tenofovir detection was much lower. And that really showed, and this was an objective metric of adherence, that self-reported adherence was high, but the actual adherence to the product in the FemPrep and Voice trials was low. There is still a lingering idea if women need higher levels of TDF-FTC to achieve the same level of effectiveness in the real world than men. At least we know from pharmacokinetic studies that vaginal tissue levels of tenofovir and tenofovir diphosphate are lower than levels of those 2 medications found in the rectal canal. However, it is important to note that in real world studies, the demonstration projects of PrEP, that it doesn't look like higher levels of adherence are needed in women than men. The IPREX Olay trial showed us in men that about 4 doses a week is what's required for high effectiveness of TDF-FTC based PrEP in the real world. So what do the demonstration projects tell us in women? Well, this is a study that is HPTAN 082 2. This was looking at daily oral PrEP as a primary prevention strategy for young African women. And you can see that in the study population, these were young women in South Africa and Zimbabwe, and they enrolled women to standard adherence support or standard adherence support plus drug level feedback and put them on pre-exposure prophylaxis with TDF-FTC. You can see that the uptake was high across all of the sites. And importantly, when they looked at drug levels, tenofovir diphosphate levels specifically in dried blood spots, there was actually waning adherence over time in the women in these demonstration projects. So started out quite high at 3 months and then went down to more 50% adherence and then 30% adherence at 12 months. However, importantly, when they looked at the rates of seroconversions in this study, there were only 4 HIV seroconverters observed in 404 person years of follow-up at months 3, 6, and 2 at 9 where adherence had waned. So what this really means is that in the real world setting, at least, even taking less than 7 doses a week, because you can see that there was never high adherence taking. Essentially, it was more on par with 4 doses a week. But even taking around 4 doses a week was very effective, at least out to 9 months in this demonstration project. This is really showing that PrEP uptake was high among young women, but that the adherence to 7 doses a week was not that high. It was more around 4 doses a week, and it really seemed to be enough to keep the HIV incidence low in this demonstration project. The 3P study showed us similar results. This is also a demonstration project among young women. And in this case, all but one had detectable tenofovir diphosphate in the first 3 months. And you can see here that there was incentives provided, and there was at least 4 doses a week adherence that was achieved with these incentives among all the women in this study. In this study with 4 doses a week adherence, there was only 1 HIV seroconversion. So 4 doses a week may be enough for women, like has been shown in the iPrexolate study for men. And it argues for actual real world studies, pharmacodynamic evaluations, rather than pharmacokinetic evaluations of efficacy. What about TAF-FTC? Well, the bottom line is it simply hasn't been studied yet or approved yet for cisgender women. It was studied in the Discover trial for men who had sex with men, and for transgender women, there were only 74 transgender women in the study of 5,200 population, and the safety at 48 and 96 weeks was good for men, but there was only 74 transgender women in this study. So what has been concluded for the approval of TAF-FTC, that it is only approved for non-vaginal sex exposures. And then in terms of the safety of TAF-FTC, and this is really important basically for pregnant women, and we're going to talk about this a little in the treatment guidelines, the TAF-FTC is essentially safe, of course, in men and women both, but there are higher rates of weight gain with TAF-FTC, at least when it's combined with dolutegravir, as seen in the advanced study. This was a randomized study of dolutegravir TAF-FTC, dolutegravir TDF-FTC, and TDF-FTC efavirenz, and you can see that essentially in women especially, there was increasing weight gain over a period of 144 weeks with the combination of dolutegravir TAF-FTC. What about our next pre-exposure prophylaxis option for women? Well, this is the Tapering Vaginal Ring, which has now been approved by the WHO. It's a silicone ring. It contains an NNRTI that we don't use for treatment orally called Tapering. And essentially, this study randomized women in phase 3 trials to the Tapering Vaginal Ring, which is actually something that is self-inserted. So there is a adherence aspect to this, the Tapering Vaginal Ring and versus the placebo ring. And you can see that the overall effectiveness was that the overall reduction in HIV was essentially 31% across the entire study by using the Tapering Vaginal Ring. Now, interestingly, this was not effective in the phase 3 trials for very young women, but that was likely due to adherence as measured by Tapering residual levels in the vaginal ring. Then the open label extension study was called HOPE, and you can see that there was essentially higher levels in the open label extension study of HIV incidence reduction, around 39%, in the setting of knowing that you are using a ring that actually has product in it. And so this was approved by the WHO for rollout in resource-limited settings. And then finally, the last prevention option for women is really intramuscular Cavitagover. And in this case, HPTN 083 study was what was performed in MSM and transgender women. And it showed that Cavitagover every 8 weeks, given it as an injection, was superior to oral TDF-FTC. However, that wasn't the study in women. The study in women was the HPTN 084 study, and that showed that Cavitagover was also superior to TDF-FTC for cisgender women and even more superior to oral TDF-FTC in cisgender women, basically more superior by a hazard ratio of about 0.89. And then the final prevention option in women is, of course, U equals U. Really what this means is that if the partner is on treatment and keeps viral loads less than 200 across many sex acts with heterosexual men and women or MSM couples, that there was really zero transmissions within the partnership if there was undetectability achieved in men who have sex with men or in heterosexual women. Essentially U equals U, undetectable in the partner equals untransmittable to the partner who's negative. Okay, so let's turn to treatment and gender-based inequalities. Well, we know that infection rates among young women are twice as high among young men in sub-Saharan Africa. In some settings, up to 45% of adolescent girls unfortunately report that their first sexual exposure was forced, speaking to the importance of HIV prevention options for women. And in low and middle income countries, average HIV prevalence among sex workers in particular is very high for women, with an odds ratio for HIV infection of 13.5. Unfortunately, despite that increased risk among women of HIV infection worldwide, PrEP availability in low and middle income countries among women and PrEP uptake among women in, for example, the United States is still lower than that it is for men. In terms of safety issues for PrEP in women, really we just have to think of two with TDF-FTC, which is still the main option right now. It really is effects on renal function and the partners PrEP study really showed us that even with TDF-FTC in healthy people, there is a slight decline in renal function and then affected bone. And of course, bone mineral density is already reduced for women versus men. So has to be watched carefully for women on chronic TDF-FTC. Let's now turn to treatment. In terms of treatment, one thing that's important to note is that women are still underrepresented in clinical trials of new HIV medications. Elbitagovir, bictegravir, these are recent integrase inhibitors, and women only represented less than 15% of the study participants in these pivotal START studies. So we really do need to keep on working on increasing the representation of women in clinical trials for treatment and in cure trials. And I will skip to this, but when women are actually included in clinical trials and included in basically phase 4 studies, there is in general a trend towards higher rates of adverse effects in women when they use the same dose as men, especially with the protease inhibitors. For example, this was a study called GRACE with darunavir ritonavir. And even though women, this was exclusively a phase 4 study in women, there was essentially a higher rate of side effects with darunavir ritonavir in women, and in fact, it led to more discontinuations. And why would there be more side effects in women versus men? Well, essentially, it has to do with increased a decreased absorption. It's really the pharmacokinetics that women have higher drug levels than men. For example, women have decreased absorption. They have slower gastric emptying times, that women weigh less, so there's less distribution and also less organ flow. And then metabolism, essentially progesterone increases CYP3A4 activity, and so there's a general trend for increased metabolism, but then elimination is slower in women with smaller organs, smaller kidneys, smaller hepatic flow. All of that put together means that in general, drug levels for many medications are higher in women than in men, which can drive higher rates of side effects with the same dose that are used with antiretrovirals. Again, speaking to the importance of enrolling adequate representation of women in the original phase 1, 2, and 3 trials of new HIV medications. Let's now turn to ART and pregnancy. Well, essentially the key background points is there are really few teratogenic drugs in general across the spectrum of medications that we use. They used to be called by the FDA Category X, and again, there are very few. Valproic acid, warfarin, methotrexate, there's thalidomide, there's certain medications that are called Category X, but that's actually very few. The problem is, though, that we don't tend to study drugs in pregnant women, and that makes it difficult to sort of understand the effects of drugs in pregnant women. So we are often flying blind when trying to determine whether a drug has a favorable risk-benefit profile in pregnancy. So this is speaking to the importance of enrolling women who are pregnant and breastfeeding in trials. As you know, dolutegravir had a 2-year history of a concern raised that it was associated with neural tube defects in the fetuses of pregnant women. So essentially the TSAMO study that was performed in Botswana at the end of April 2020 looked like there was a signal for increased neural tube defects. This was first noticed in April 2018. Then with each subsequent look at the Botswana cohort, which was comparing efavirenz versus dolutegravir in pregnant women, that neural tube defect increase actually decreased that concern. And by the end of April 2020, we had lost that concern. But that is the problem with observational studies. And so now dolutegravir is, of course, first-line therapy worldwide. And here in the United States, dolutegravir is a preferred medication as an INSTI. And as of July 2019, it was first-line by the WHO. What drugs are not recommended in pregnancy? Really, the main one to remember is cobicistat. Anything containing cobicistat, which is a pharmacokinetic enhancer, those levels are decreased in pregnancy. So we're concerned about using anything that contains cobicistat in pregnancy. Otherwise, what's on the right is really not enough data, but we're getting more and more data on the safety of TAF in pregnancy. This was the IMPACT 2010 trial, and the safety of and just with time, we'll get more sort of observational data on the safety of these other medications. We also have to worry about pharmacokinetic changes that occur in pregnancy, and remember dose adjustments that are required. There's even slower absorption of drugs in pregnancy with slower GI motility during that phase. Progesterone does increase hepatic metabolism, so that is those levels are increased. Progesterone's increased, of course, in pregnancy. And distribution is actually lower because of expanded intravascular volume. And then elimination is actually faster in pregnancy because of increased renal blood flow. In general, all of these changes lead in general to lower drug levels in pregnancy, which is why we have to increase the doses of some of our antiretrovirals during pregnancy. It's important to remember that patient preference is the most important consideration in pregnancy. If a patient is on a drug that we don't know a lot of aspects about its side effects, switching can be disruptive. If they want to stay on it, we in general keep patients on their medications as they approach pregnancy. And these really speak about the values and preferences of women who are living with HIV, who are pregnant. They are concerned about side effects first and foremost, then desire to reduce vertical transmission, then concern about side effects to the child, desire for the child to be healthy, and desire for oneself to be healthy, and pill burden. So think of all of those factors when you choose your medications for women in pregnancy. In general, what are some other considerations for these medications? Efavirenz, there was an initial concern about neural tube defects that has disappeared in humans and is perfectly safe in pregnancy. Rilpivirine, just to remember, this is a drug that we can't use with proton pump inhibitors or other drugs that decrease gastric acidity, which just means that we have to be careful in the setting of pregnancy. Raltegravir, remember about this is that we have to never use the lower dose. We can't use the 1,200 milligrams daily. We need 400 milligrams twice a day in pregnancy because that's all that's been studied. Dolutegravir is the preferred single pill combination for pregnancy. And then atazanavir and darunavir, there are some recommendations to increase the levels of darunavir during pregnancy to go up to the 600 milligram BID, ritonavir, 100 milligram BID in pregnancy. What we have to monitor during pregnancy is, of course, viral loads carefully. CD4 counts only need to be monitored at the beginning or if they're detectable viral loads, and just typical pregnancy labs, and certainly being very aware about glucose screening in women living with HIV. And finally, it is safe for women in pregnancy to take TDF-FTC for pre-exposure prophylaxis. And in fact, this can be a time where it's very high risk to seroconvert to HIV. So it is very much encouraged if there's ongoing risk during pregnancy to take TDF-FTC for pre-exposure prophylaxis. And always important to remember to discuss pregnancy desires with women living with HIV early on in the course of their care. In terms of contraceptives, to just sort of put it all together in a very simple way, there are interactions between NNRTIs and Depo-Provera. DMPA is preferred. It is the preferred agent with efavirenz and not other there are more interactions with oral contraceptive pills with efavirenz. In general, with the PIs, DPMA is also preferred, and oral and implants are not preferred. And that's specifically with darunavir, ritonavir, and with atazanavir and lopinavir, all methods are fine. And then finally, with INSTIs, integrase inhibitors, no concerns with all forms of contraceptives and integrase inhibitors. So it is important to, again, bring it back to women of reproductive potential. They are certainly pregnant only certain times of the life cycle, and it's important to remember that women should be offered anything that men are in terms of medications or what they prefer to use. The burden of justification needs to be moved from excluding women in clinical trials to including them in clinical trials, because it's important to know the effects of drugs on pregnancy. And in fact, the FDA has really put out a statement very strongly that we have scientific and ethical considerations for the women who are pregnant in clinical trials for designing adequate drug trials. And then I will just end with primary care for women. Just in general, primary care screening for women living with HIV is essentially the same as for women without HIV, with one important difference, and that difference is really around bone health. So in terms of breast cancer screening should be done typically as it is done for women without HIV. In fact, HIV is a risk factor for certain types of cancers, as you know, but it is not associated with increased risk of breast cancer. So routine screening for breast cancer in women with and without HIV is acceptable. The same is true of cervical cancer screening, that essentially we should be screening all women with HIV aggressively. The age to start screening is young, and cytology should be performed if there is abnormal PAPs. But it is important to remember that if there are no abnormal PAPs and there's a stable sexual relationship, that we can go to every 3 years between the ages of 30 to 65 in women living with HIV. Menopause is a particularly important time for women living with HIV because there can be enhanced menopausal symptoms. The symptoms of menopause are really heightened by HIV. And that menopause transition is an important time to monitor. In addition, physical function can be lower in women living with HIV when they're older than men. And essentially, because of that, it's important to think about geriatric conditions in our older women living with HIV. That means frailty, osteopenia, osteoporosis, and physical function. Even cognition in a women's interagency HIV study shows that there is heterogeneity in cognitive aging among women and men living with HIV, but women living with HIV may be more cognitively vulnerable than men living with HIV. And then in terms of bone health, it is important to aggressively start screening women when they're when they're postmenopausal and men is over the age of 50 by DEXA screening, and keep on thinking about their bone health, because women with HIV, because of the HIV infection itself, because of the use of tenofovir compounds, are more at risk for bone loss than their counterparts living without HIV. So I will end with the fact that we went over HIV prevention strategies in women, HIV treatment strategies in women, ART in pregnancy, and primary care. And thank you so much for your attention.